Madam, we are live. We can start.
Okay. So, good afternoon, dear sir and ma'am. It's been great pleasure on behalf of API Vellore branch to host this South Zone PG Master Class. So today, the presentation from Christian Medical College and final year postgraduate will present about the valvular heart disease. So over to you, CMC team, to take over the case and proceed the presentation.
Good morning, everyone. I'll be presenting a series case today. So, presenting Mrs. N, a 55-year-old lady, 55-year-old lady who from Bihar, who a housewife who presented with the complaints of dyspnea for past 10 years, chest pain for the past 10 years. So, history of presenting illness. She was apparently normal before 10 years when she developed dyspnea, which was gradually progressive in nature, initially NYHA grade 1. Since 1 year, her breathlessness has progressed to NYHA grade 2. Her effort tolerance has reduced from 500 meters to around 100 meters. Breathlessness is aggravated on exertion and is not associated with orthopnea or paroxysmal nocturnal dyspnea. She also complained of chest pain for the past 10 years, which has been more frequent since the past 1 year, which is central and which is exertional and relieved by rest. She also had palpitations for the past 1 year, which are intermittent in nature, brought on by exertion and relieved with rest. There was no history of syncope. However, she did mention occasional giddiness and suddenly getting up. There was no history of cough with expectoration or hemoptysis. There was no history of fatigue, no history of abdominal distension, fetal edema, or decreased urine output. There was no history of fever, joint pain, or any painful nodules. No voice change or dysphagia. So, coming to the past history, 30 years ago, during her second pregnancy at term, she had similar complaints and was diagnosed to have with a heart disease. She was managed conservatively and discharged for the same. 5 years later, she had similar complaints and was diagnosed to have a mitral valve disease, for which she underwent a balloon procedure in 2000. She also has comorbidities of asthma. She has type 2 diabetes mellitus since the past 10 years. She has hypothyroidism since the past 10 years. She denies any history of fever, sore throat, skin lesions, joint swelling, or breathlessness during her childhood, or receiving injections every 21 days. Coming to the family history, no family members have any cardiac disease, no cardiac surgery, or sudden cardiac death in the family. Personal history, she gave no history of any habits of smoking or ethanol consumption. She consumes a mixed diet. She has attained menopause at around 10 years ago. She gives no history of any significant weight gain. So, coming to the summary of the history, presenting Mrs. N, a 55-year-old female who presented with complaints of progressive dyspnea from NOHA grade 1 to 2 with effort angina and intermittent palpitation with significant prior mitral valve history with an undergoing a balloon mitral valve valvoplasty around 25 years ago.
So shall we stop at this, at this point and go back to the, history? So I think you've taken a very good history. So this is a 55-year-old lady?
Yes, sir.
Okay. And she's coming from Bihar. And her main complaint is dyspnea. Yes. And also chest pain. But is the chest pain for, is it for the last 10 years or is it for 1 year?
I say it has been there intermittently, with the frequency has been more since the past 1 year, sir.
Okay. So how would you approach a patient who has dyspnea history wise? Which systems could get involved, and how would your history help in finding out where the problem is?
So dyspnea could be secondary to could be related to cardiovascular system, respiratory system, secondary to anemia per se, anxiety related, or also GI related also.
So it's good to think of why somebody gets dyspnea. So how do you define dyspnea?
Sir, it's the unpleasant awareness of one's own breathing, sir.
Uncomfortable awareness of one's own breathing. So how does somebody become aware of dyspnea?
When usually when they are either when they are breathing faster or not, they are not able to compensate for adequate.
So think of the receptors which mediate dyspnea
The
from the chest wall. Okay, somebody is not getting enough oxygen, breathing fast. That sends a message to the brain, and that's how you become aware. So at the end point of all that happens from the time that we breathe oxygen to the point where oxygen reaches the cell, things could go wrong, and if it goes wrong, somebody's going to have dyspnea. So largely with systems, it's either CVS or RS, or sometimes it could be the hemoglobin with the problem. So what history would you ask to find out whether somebody has involvement of respiratory system?
respiratory system involvement, cough preceding breathlessness could be a helpful history. A presence of seasonal exacerbations, presence of a wheeze per se.
Okay.
This history could be a past history or family history of atopy, or could be helpful towards a respiratory illness.
Okay. So you think of the whole respiratory system. What if somebody has, let's ignore that the history of chest pain for now. If somebody has larger airways involved and they are breathing difficulty, what other symptom will they have? It may not be chronic, but it could be acute also. Larger airways,
Noisy breathing,
stridor.
Right.
Okay. Smaller airways,
a wheeze or a wrong.
wheezing. So then if they have wheezing, then go on to ask about whether there is seasonal exacerbation. But we know that if there is wheezing, the smaller airways are involved. What about the alveoli? Dyspnea, and if it's an alveolar cause which is causing dyspnea, what other symptoms will they have?
They can have
Cough,
cough.
and with sputum.
Yes, sir.
Okay, a lot of sputum. Could be infection, or it could be malignancy, or could be blood. So alveoli is involved. You have cough and sputum. Okay. What about interstitial?
It'll be more of a dry
More
cough.
of dry cough. Okay. Of course, you can have dyspnea even because of involvement of pulmonary vessels.
Yes.
So that can cause dyspnea. May not have any of the other symptoms. What about pleura?
They'll have pleuritic kind of pain usually. Sir.
Pleuritic chest pain, if it's an acute, inflammatory, very localized pain. What about if it's if it's chronic and something infiltrating? What kind of pain? It may be a constant pain in the pleura. Okay, it could be a chest pain, may not be like the angina. What happens to the chest pain if somebody has pleurisy, and then initially there's chest pain, after some time chest pain disappears?
That is probably because of fibrosis and
or the fluid which appears. Initially there is pleural inflammation.
Yes.
Once the fluid appears between the two layers of pleura, this chest pain is going to go off. So you do have to go into details to find out where the problem is coming from. We'll come to CVS, but if it's blood loss, what other history would you ask? Blood loss, or if it's due to hemoglobin is a problem, of dyspnea, what other history would you ask?
If there have been previous transfusions, if there is any evidence for blood loss, barefoot walking,
like
Malina, any history of
MFMSS, Malina, transfusions. Here, asking diet history is important. Whether they are, taking a mixed diet, or are they taking only a vegetarian diet? That's important. That'll tell you whether they have a vitamin B12 deficiency. Coming to heart, which part of the heart will cause what kind of symptom? What are the very largely the parts? There is, there's pericardium, there's myocardium, and there's endocardium. The symptom itself will, tell you which part is involved. So what kind of symptom will somebody have if there is involvement of pericardium?
They can have pericardial pain.
Okay. And what history would you ask to find out if they have involvement of pericardium?
On taking deep inspiration, they may have pain, pericardial or
Okay.
pleural
And
kind of pain.
how is it relieved in general?
So usually lying down worsens it, and sitting up in front actually relieves a pericardial kind of pain.
Leaning forward relieves it.
Yes, sir.
Okay. And if there is, let's say, a massive effusion, what kind of symptoms will they have? Pericardial effusion.
Breathlessness.
Breathlessness, because obviously
The
both the
heart is
ventricles
not-
are compromised, but can also have right ventricular symptoms.
Okay.
Long-standing involvement of pericardium, what kind of symptom will they have?
They'll have a
It'll be predominantly a right heart symptom. And what symptom? Ascites, pedal edema,
fluid over
etc. Okay, so that's pericardium. Which condition can cause long-standing involvement of pericardium?
TB.
Okay, so constrictive pericarditis, which could be TB, but could be idiopathic also. Okay, then we come to myocardium. What symptoms do you expect?
Myocardial chest pain. There can be anginal kind of a typical angina kind of a chest pain with radiation.
Okay.
And
so in general, if there is less blood supply to the myocardium, you're going to have chest pain, or an acute obstruction of blood flow to the myocardium. That's also going to cause an acute pain. And what kind of pain will that cause? Acute obstruction. Acute could be MI, which is severe chest pain.
Yes.
Will it be relieved with sublingual nitroglycerin?
Yeah.
MI pain?
Yes, it will be relieved.
Not immediately, isn't it? It's not going to relieve. That's when you come to the hospital. But somebody walks, then gets chest pain, then we're thinking of less blood supply to the myocardium. In which case we'll have to think of either atherosclerotic block, or it could be, if it's a valvular heart disease, which one?
Angina will be there in aortic stenosis.
And also in aortic regurgitation, both can cause. Okay. That's of course, that's valvular. So we have the various valves, which that's the endocardium. Which symptom will be the predominant symptom in each of the lesions? Mitral stenosis, what will be the main symptom?
Dyspnea.
Dyspnea on exertion. That's the main symptom. Okay. What about mitral regurgitation?
That also
So there it could be, remember, it's a regurgitant lesion. It could be an exertional fatigue, or exertional dyspnea, or exertional palpitation. You could remember the mnemonic FTP. Okay. Fatigue, dyspnea, and also palpitation. What about aortic valve?
Aortic valve, they will have angina, syncope,
So
dyspnea.
AS, let's say somebody has a mild to moderate aortic stenosis. What will be the main symptom?
They can have syncope.
For a long time, they're not going to have symptom. Okay. If they have symptom, that means it has become severe AS. And what are the common symptoms? ASD, angina, syncope, and dyspnea. And AR, it's a regurgitant lesion, so it's going to be
fluid. Again, they can have heart failure symptoms.
Palpitations. Because moment you have a regurgitant lesion, you're going to have a lot of palpitations. Palpitations, dyspnea, angina, TDA. Okay, like approximately, these are approximations. Of course, there can be a lot of overlap. This will sort of tell you which valve may be involved. So what are the main symptoms in your case?
Sir, dyspnea, angina, and intermittent palpitations, sir.
Okay. And she's had repair of the mitral valve before.
Yes.
So you already have some clue that there is involvement of mitral valve, but she also has palpitations. She also has angina.
Yes.
She also has dyspnea. So which other valve is likely to get involved?
Because there is some features of angina and some pre-syncope, I would think maybe aortic valve is also involved.
Okay, if aortic valve is involved, what lesion should you be thinking of?
Because syncope, pre-syncope kind of a presentation is also there, aortic stenotic kind of
Stenosis, but we can't say
completely.
that there is no AR.
Yes, sir.
There is, there's a likelihood that there is
There could be
AR.
an AR.
Okay, so if you at the end of history, if you were to say which valve is involved, what would you say?
Both mitral and aortic valve could be involved because alone I can't explain all the symptoms.
So what kind? Is stenotic lesion, regurgitated lesion?
Stenotic, predominantly stenotic lesions, sir.
Okay, so aortic stenosis, but there is palpitation and there is so you should think of regurgitation lesion.
Okay.
Mitral valve, what will she have? Stenosis or regurgitation? She's already had a repair. So what is she more likely to have?
Stenosis because she had a balloon procedure, likely
Okay.
that she would had a stenosis. That's why she
Okay.
underwent.
So she had a balloon procedure. She didn't have a repair.
No, sir.
Did you say she had a balloon valvuloplasty?
Yes.
Okay. All right. Okay. So possibly mitral stenosis and possibly also aortic stenosis, aortic regurgitation. These are the things which you consider. So that's the valve involvement. In terms of pathology, what do you think is the cause?
It's a long-standing condition,
Okay.
and she's 55 years old, and this is started at around 25 years. So probably a rheumatic etiology I would like to consider.
Okay.
Though there is no clear rheumatic fever history that she remembers of, which a lot of people may not remember.
Okay. So you think it's rheumatic. Suppose she's 55. Let's say her symptoms are just for a few years, and with a similar symptom, what would be the etiology?
The ischemic should be considered, an ASD kind of a picture.
If the valve complaint is the same, what other conditions? May not be 55 or even a bit older. Calcific. Okay.
Degenerative.
So more likely to be degenerative.
Sure.
I think increasingly we'll see more and more of those causes rather than rheumatic heart disease, because rheumatic heart disease has come down, significantly. Have you managed anybody with rheumatic fever? Not really. I don't think we've been seeing patients with, at least in CMC, we're not seeing. Maybe once in a year we might see a rheumatic fever case. This incidence has come down significantly. Okay, and in terms of so she doesn't really give history of rheumatic fever, isn't it? But as you said, they need not have history of that. A lot of patients may not really remember. So any other significant history that you've got? So she has asthma, well controlled, diabetes, hypothyroidism, all that. Any significant family history?
No.
Okay. Did you ask social history? What about a socioeconomic history?
No.
Okay. So which socioeconomic group is more likely to have rheumatic heart disease?
Low SCS.
And you might have, if the family members give a similar heart disease, that overcrowding does, predispose. So that is something you should ask for. It's good to do that, the Kupaswamy scale for you to understand which socioeconomic strata she is from. Next, after personal history, have you got anything?
No.
What about medications? What is she on at present?
So she was actually, I failed to mention, she has actually been taking a medication at 6 p.m., likely to be an anticoagulant. And she also probably is on a diuretic because she's taking a medication which increases her urination, sir.
Okay, so most likely to be a diuretic.
Diuretic.
Okay, all right. I'll ask Karthik to ask you guys.
Yeah, so the predominant symptom was more like dyspnea and angina. So what does it suggest? I mean, when you're looking at valvular disease, you need to see which is the predominant this thing, whether it's if you can classify as whether it's a pressure overload system or a volume overload system. So as for your history, you're thinking more of a
Stenotic.
like a pressure overload.
Pressure overload.
Yeah. So if you know it's a pressure overload, so the common symptoms would be dyspnea and angina.
Okay.
Whereas in a volume overload, you'll have more of fatigue and palpitation. So first thing to do is to classify them as whether it's a predominantly a pressure overload state or a volume overload state, and then have a focused examination so that becomes easier for you. So yeah, it sounds more like a pressure overload state. So we are thinking more of a stenotic lesion, probably involving the mitral valve plus minus the aortic, because she also had some syncope you mentioned. So that is the only thing which kind of gives us a clue saying it could be aortic also involved. Or I would probably say that she's predominantly got a mitral stenosis, and probably whether she's got a other recurrent lesion like an AR, we need to look for in the clinical examination meticulously.
So at the end of your history, do you want to, do you want to commit yourself to some diagnosis?
No.
What's the diagnosis at the end of history? We did do a symptom analysis.
He,
Discuss the pathophysiology.
Yeah.
So you can tell us.
Yeah, you can confidently. Of course, your examination will also give you some clues.
so she predominantly came with a dyspnea and then followed by an angina kind of symptoms with intermittent palpitations and pre-syncope kind of episodes. Symptoms are all towards a pressure overload as mentioned by sir. So we were thinking in line of a stenotic lesion, and because there's a past history of a mitral valve being involved and dyspnea being involved, there's a mitral valve going to be involved. The angina has to be also be explained. So we are thinking there's possibly an involvement of aortic valve also. So multivalvular heart disease probably, likely maybe rheumatic in origin because of the young age presentation and the fact that two valves are simultaneously being involved.
And she got intermittent palpitations.
Yes, sir.
It's not exertional palpitation.
It's exertional, but she's not having regularly, sir.
So if it's intermittent and it's not exertional, what is it likely to be?
Could be a paroxysmal and
Maybe an atrial fibrillation that's coming, which is not uncommon with somebody with mitral stenosis. But that is something to keep in mind when you examine. You would look for whether she's got atrial fibrillation. What if she's got atrial fibrillation? If she's got mitral valve involvement, what is she at risk of?
for thromboembolic events, sir. Stroke.
Okay. That's something which you need to ask in your history, whether she's had any TIA, any stroke before. Did you mention that in your history? Okay.
No.
Okay. All right. Let's go to the examination finding.
Coming to the general examination, she is conscious oriented time place person. Her height is 152 centimeters, weight of 62.5 kilograms, BMI of 27.05, BP, forearm BP, left arm 110 by 60, right arm 104 by 60, left lower limb 100, 100 systolic, right lower limb 100 systolic. Her pulse was 80 per minute, irregular, variable volume, no radiofemoral delay, all peripheral pulses were felt. Her heart rate was 96 per minute with an apex pulse deficit of 16 with a respiratory rate of 18 and JVP was elevated at 6 centimeters from the sternal angle. She is moderately built and nourished. Pallor was present. No icterus, sinuses, clubbing or pedal edema. Fundus was normal. No peripheral signs of aortic regurgitation were noted. There were no other peripheral signs of atherosclerosis. No peripheral signs of infective endocarditis. Coming to the cardiovascular system examination, on inspection, chest wall was symmetrical, apical impulse was not visualized, tracheal position appears to be in midline. There were no dilated veins, scars, precordial bulge, epigastric pulsations. Palpation, tracheal position was confirmed to be in the midline. Apical impulse was felt in the left fifth intercostal space, lateral to the midclavicular line. The nature of the apical impulse was noted to be tapping in nature. The palpable P2 was noted in the pulmonary area. There was no parasternal heave that was appreciated. Coming to the auscultation, in the mitral area, first and second heart sounds were heard. Variable first heart sounds were heard. There were no S3 or S4. A low-pitched, rough rumbling, mid-diastolic murmur of grade 4 was heard with the bell of the stethoscope. Best heard is the left lateral position with breath held in expiration. In the tricuspid area, there were no murmurs heard. First and second heart sounds were heard. Coming to the pulmonary area, first and second heart sounds were heard with a loud P2. There were no other murmurs that were heard. In the aortic area, first and second heart sounds were heard. A crescendo decrescendo ejection systolic murmur, grade 3, heard with the diaphragm of the stethoscope, and which conducted to the carotids with patient leaning forward and breath held at expiration was noted. Other systems examination, respiratory system, there was normal vesicular breath sounds heard in all the areas. There were no basal crepitations. Abdomen was soft, not distended. There was no organomegaly, no free fluid. Trops was resonant. She was conscious, oriented, time, place, and person. There were no focal neurological deficits or any upper limb or lower limb weakness. Summarizing, a middle-aged 55-year-old female with irregular variable volume pulse, elevated GVP, normal pulse pressure with an apical impulse which was lateral to the mid-clavicular line, with a variable S1 heard in mitral area, with an MDM murmur heard in the mitral area, which was grade 4, and where there was a soft S2 with an ejection systolic murmur heard in the aortic area.
Okay, so I think you've done a good examination. The downside of an online clinic is that we can't cross-check the findings. You've checked BP in all 4 limbs. That's good. The BMI is 27.05, isn't it?
Yes.
Okay. Usually at least few years back when we used to see a lot more cases of the rheumatic heart disease, typical case would be a young lady, very thin and emaciated, long-standing mitral valve involvement, mitral stenosis. You do expect the BMI to be much lower, but looks like her valvuloplasty has done the work, and she's done well for many years, and looks like there's been a restenosis again, isn't it? And she does have an atrial fibrillation.
Yeah.
Okay. Can you move on to the next slide? Right. And what kind of peripheral sign of aortic regurgitation did you look for?
As a Hill sign, any systolic difference between the popliteal and the brachial this thing more
Okay.
than 20.
Okay. What's Muller's sign?
Muller sign is uvula's
Pulsating uvula. And what is D. Masset sign?
D. Masset sign is the diastolic murmur heard in the femoral region. Sir.
Okay. And what is what's Quincke's sign?
Sir, the pulsations in the capillary refill.
Okay. Have you seen a Quincke sign?
Yes.
Okay. Name some peripheral signs of infective endocarditis which you looked for.
Sir, osseous node, Janeway lesion, Roth spots.
Okay. Next slide. So she's got a MDM
Yes.
in the apex and a ejection systolic murmur in the aortic valve, and there is loud P2, palpable P2 as well.
Yes.
Okay. What other murmur did you look for? Like, did you do some special maneuver and looked for any other murmur? If you were to carefully examine and look for this particular murmur, because at normal auscultation, just patient lying down, you may not really, it's possible, you can miss a murmur. So leaning forward, did you look for a aortic regurgitation murmur and early diastolic murmur? No. Okay, that's something which you have to do that. Okay, there's a good possibility you might, we might actually miss it. So both cenotic lesions, what is not explained is the palpitations. So whether she has a MR murmur, will usually be very well heard. She has no pansystolic murmur. So whether she's got an underlying AR is a question. You have to make the patient lean forward and listen carefully, using the pedal of the steth. Patient leaning forward, breath held, expiration. Otherwise, there's a possibility you might miss it. I'm not saying you have missed it, but it can happen. Okay, that's something which you have to do it. Do the maneuver, just like how you do the left left lateral position for the MDM. Okay. Karthik, any comments on the examination?
Just go back to first slide. Yeah, again the blood pressure 110 over 60. What does it tell you?
There's a normal pulse pressure, sir.
What is the normal pulse pressure?
30 to 60.
30 to 60. But this is tending towards
High.
the higher side, no? So again, what Dr. Ronald had mentioned, so you need to look for
Concurrent.
underlying regurgitant lesion because
That
your
could
pulse
be
pressure, if you got a 2 stenotic lesion, your pulse pressure would have been on the
much
lower
lower.
side, less than 30. So what we see here is not something internally consistent. So definitely you need to look for a regurgitant lesion over here. Yeah, next slide. Next slide. Next slide. Okay, there was no parasternal heave, but she's got signs of pulmonary arterial hypertension. And if you got an MS, definitely would probably will find a parasternal heave to some degree at least. Next. Next. Okay, next. Okay.
So at the end of history and examination, what is your diagnosis?
Probably an acquired valvular heart disease, probably rheumatic in etiology. Probably an acquired valvular heart disease, probably rheumatic etiology, sir, with mitral stenosis and aortic stenosis. Probably, as mentioned, I should have looked more harder for a probably underlying aortic regurgitation also, and with pulmonary few features suggestive of a pulmonary arterial hypertension like a loud P2, so there was no parasternal heave in atrial fibrillations with no features of active heart failure or infective endocarditis.
Yeah. So she didn't have any pulmonary edema. Sorry, any fetal edema?
No, sir.
No.
She was probably on a diuretic also.
She's on diuretic. Okay. All right. So any other differential you would consider for the etiology?
Because she has comorbidities like diabetes, the aortic can also not be rheumatic. Maybe the mitral was rheumatic and the aortic could have been degenerative or secondary.
I mean, yeah, it's possible, but most likely, if it's rheumatic, it's it's going to be rheumatic, isn't it? Which valvular disease is more common in female patients? Mitral valve disease.
Mitral valve.
Okay, and both mitral and aortic, or only aortic, is more common in males. And what's the difference in terms of presentation of rheumatic heart disease in Indian patients as opposed to patients from the West?
They may be presenting later than the Western patients. Because of the low SES, they may be presenting in a much advanced stage.
Yeah, and generally the patient, the time between rheumatic fever and development of rheumatic heart disease is much shorter in the Indian patients, and also they seem to come at a very younger age. So the duration is also shorter, and age of presentation also is shorter. Of course, because there is we are still a developing country. We do still have some rheumatic heart disease, whereas where the socioeconomic ladder has gone up, in general, the rheumatic fever also goes off, and it seems to be much lesser. What do you think some of the reasons why there is less rheumatic fever now?
Much easier access and availability to antibiotics.
So people can have sore throat, they go to a doctor, or they go to somebody and get antibiotics sooner. So obviously we see less and less of streptococcal throat infections leading on to rheumatic fever. Okay, so this is your history, and what if you were to choose one test that you would do to confirm your diagnosis? What would you do?
I would like to do an echo to confirm my valvular finding.
Good. So that would be the most important test, and of course we need some more supportive tests as well. So you would do an echocardiogram. What other tests would you do?
I would like to, because there was pallor, I would like to do hemoglobin, her current hemoglobin status. I would like to know her creatinine also, because we are going to be giving her diuretics and other medications. And I would like to also do a chest X-ray to look
We have
for
to also do some electrolytes, sodium, potassium. She's on, furosemide.
Yeah.
So even while doing a hemoglobin, good to do the complete blood count. Okay, then
I would also do an ECG, because we are saying there's an irregular pulse to look
Okay.
at the atrial fibrillation. And I would also plan for, in this patient, maybe we'll have to eventually plan for an angiogram also if we are planning for a valve replacement.
Okay, good. And would you do a X-ray of the chest as well?
Yes.
Okay. Even if she's not an acute failure, it's good to have a baseline if you're going to admit her. So chest X-ray will also give you clues about what's happening in the lung as well. Any other tests? I think that largely covers what is needed at this point in time. And echo shows severe mitral stenosis, severe aortic stenosis. What would be the next step in management?
Because there is dual valve involvement, she should be undergoing both valve replacement ideally. She's already had a balloon valvoplasty, now come with both valve lesions. She should be undergoing valve
Okay.
replacement.
So seen by surgeons, and they're saying has to be operated, but she's not willing at the moment, and you have to manage medically. What would be the larger principles, in keeping her on medical management until she's ready for surgery?
Because she has atrial fibrillation, anticoagulation we should be considering, ideally warfarin or a vitamin K antagonist we should be starting her on. Diuretics we can use for acute heart failure management. And
Would you
also,
give apixaban, rivaroxaban,
no, sir,
Dovax? Why
we
not?
don't have evidence for
Okay.
valvular heart disease
So the trials have not
benefit.
yet shown a benefit for valvular AF. So we have to fall back on, warfarin.
I would
What?
also I would also consider giving beta blockers for rate control if the heart rate is not being controlled.
Okay. What other drug would you give? So anticoagulation, beta blockers, anything else?
Diuretics,
Diuretics. Anything that you would avoid in this patient in particular?
ACE, ARBs I will not give.
So vasodilators. So you have two stenotic lesion or even one stenotic lesion. You don't want to give vasodilators. So ACE, ARB, even calcium channel blocker, you would not give initially because until the surgery is done, because that's gonna cause a drop in blood pressure, leading to adverse outcomes. So you would want to avoid vasodilators at this moment. Karthik.
So, as per your presentation, she's got MS and AS. Right? Why do you say she's got an MS? What are the
She-
clinical?
Clinically, sir, one, the initial history wise, there is a dyspnea. There's dyspnea and chronic dyspnea that is more than 10 years. Probably, usually the mitral valve involving history is a prolonged history which is slowly over time developing. So that is towards valvular pathology towards mitral valve. And then on examination wise, she has atrial fibrillation, which also is seen more towards a mitral valve pathology. And then our osculatory findings also confirm the fact that there is an MDM, which is probably why we are saying there's a mitral.
So what are the other conditions where you can have MDM?
For MDM, you can have in amyloidosis, we can have in mucopolysaccharide MPS 1, 2.
No, mid-diastolic murmur. MDM you meant was a mid-diastolic murmur, no? So which
Yes.
are the other conditions where you can have a mid-diastolic murmur?
Stenosis is one. What else can cause That's total power.
On auscultation, what all do you get in MS? What happens to S1?
There's a loud
It's usually loud.
Yeah.
Then what else do you get?
Any other sound?
opening snap.
Okay, did your patient have an opening snap?
No, I didn't appreciate an opening snap.
Then she had the murmur. She had an MDM. Any other presystolic murmur she had, or presystolic accentuation? What do you expect in this patient?
She could
Probably not, because she was an AF. We don't expect a presystolic accentuation in a patient who's got a MS and who's an AF. Okay, so other causes for somebody with an MDM could be acute rheumatic fever, CARICOMS, murmur,
sure.
and can AR cause an MDM?
Austin Flint murmur.
What is it?
So because the jet of the aortic regurgitation will prevent the anterior leaflet to completely close and thereby causing a pseudo MDM kind of mitral stenotic kind of a
Can this
murmur.
patient be having an AS and an AR? And whatever MDM you're hearing is just an Austin Flint murmur?
Because if there was AR, there should have been the apex is not down and out. Usually we expect a down and out kind of a apex that will be here. It is only out.
Yeah, predominantly it'll be a volume overload
Volume
where you
overload.
have your apex being shifted down and out. But here we don't see that, and we are not seeing any other signs of peripheral signs of AR.
Yes.
So you're saying it's an MS and an AS.
There could
So
be a
with
mild
this,
AR,
so
which I would have not appreciated.
based on your history and examination, which you think is the predominant valve which is involved in terms of severity? You want to say it's a severe MS or a severe AS?
I would say it's a severe MS with a moderate AS.
Why are you saying it's a severe MS?
Probably because the long-standing nature and the dyspnea on exertion.
So what are the clinical signs to say it, call it as a severe MS?
Valve severity can be based on valve area, can be based on prolonged how
Well,
prolonged
area
the
is not something clinical.
the duration of the diastolic murmur.
Okay.
The aortic stenosis A2OS we can look at.
No, MS. You have a small pulse pressure. Okay. When your gap between your S2 and your opening snap decreases. Okay, so those are some of the clinical, and you have features of pulmonary arterial hypertension. Okay, and what about AS?
Again, presence of S3 is something that indicates clinically that this might be a severe AS. The decrease at A2OS will indicate reversal, and then A2P2 reversal will indicate that is a severe AS.
Okay, so by the end of your history and examination, you should tell us which is the predominant at your level. You should tell us which is the predominant valve and the severity that is also expected.
Any symptom in AS means, she has severe aortic stenosis. So that she has symptoms. She has angina, she has syncope, and which is normally we don't see in mitral stenosis. Angina and syncope.
Yes.
So she likely has severe aortic stenosis, and then she has pulmonary arterial hypertension. So most likely she's got a severe MS also. Of course, the sensitivity and specificity of all these symptoms to diagnose severity may not be really high. So you have to do an echocardiogram for us to say with confidence what it is. Is that your last slide? Oh, go ahead. Yeah.
Just the investigation as mentioned before, sir, and the management as we had mentioned.
Is that Hershey's X-ray?
Yes.
Okay. What does it tell you?
So the chest X-ray has some splaying of carena. The left border is straightened out. Left heart border has been straightened out, and yeah, predominantly that these are towards features of a MS.
There's some haziness in the left lower zone also.
Sure.
Probably has some pulmonary edema as well. There is no calcification of the aortic vein, that is very obvious. Okay.
ECG showing
What does it tell you?
It was showing atrial fibrillation, but is not showing any features of RVH or an LVH.
Okay. And what is the main thing that that you would look to say that it is atrial fibrillation?
Absence of a P wave, sir.
And the other feature, varying RR interval.
Oh, yes.
Okay. So both are there. Were you able to locate a P wave? No. It's not. There's some notches seen, but they don't appear to be a very clear P wave. Okay. Forward. Next slide. Okay. So we don't have the echo findings and for this patient. Okay, I think overall, I think it's a good case with two valvular lesions with classic symptoms, good mid-diastolic murmur, ejection systolic murmur, which you picked. You have to make a special effort to listen to early diastolic murmur, and do go back and read on how to identify the severity of the mitral valve and mitral stenosis, aortic stenosis. Those are some things which will be asked during exams, and it's good for you to be prepared for that. Yeah, so that's all from my side. Any closing comments from Karthik? Do you have any comments? Are we on? Okay, so if sorry. Dr. Anita, do you have any closing comments? If there are no other closing comments, I think we can close for the day. I just want to thank all of you, who are here in person, as well as people who have joined online. Special thanks to Ritesh for taking on the case in the last minute, and overnight is worked up and made this presentation. So thank you, Ritesh. And we'll meet next week for the next class. So thank you.